Wonderful. Thank you so much, Cassidy, and thank you for giving me the opportunity to do this webinar today on this important presentation for Pricing Transparency Initiative. You can go on to the next slide. I think this is just the HRSA funding statement. Would you like for me to read this, Cassidy, or do you want to go to the next slide? All right. So the American Hospital Association has created a toolkit for the Pricing Transparency Initiative, and one of the things that they tell us in that toolkit is just that consumers and their families deserve useful information about the price of their hospital care. And of course, demand for understandable price information will only increase as patients shoulder an increasing proportion of their healthcare costs. I do reference at the end of this webinar the toolkit. Some of the information that I'm providing you today is through that, and I'm going to go through, first of all, just a little bit of history about how the pricing transparency timeline has come about, and then I'm going to go through the information in the final rule for the pricing transparency that came out in November, give you an action plan, and provide you a little bit of information about chargemaster pricing and the importance of the accuracy of the pricing, and then we will end with some Q&A. Next slide, please. So really, pricing transparency isn't brand new to us. It started with the Affordable Care Act back in 2010. That's when the original request came about for us to post our standard charges, hospital charges, to a website, and it wasn't mandatory at that time. It was just a suggestion or a request that that be done. Then in the 2015 Inpatient Prospective Payment System final rule, we were reminded by the Centers for Medicare and Medicaid Services that request was still there. It was still not mandatory, but we were asked to post our hospital standard charges to a website. Then in the IPPS final rule for calendar or fiscal year 2019, that information was updated, and it told us that we would have to post our current standard charges via the internet, and they were making it mandatory as of January 1st, 2019. Next slide, please. So in 2019, as of 1/1, we were to post all of our standard charges via the internet in a machine-readable format, such as Excel format. That's the one that I see most frequently, and then update at least annually. And at that time, there was no mandated penalties as of January 1st, 2019. I think I was told from some hospitals that they had received letters from CMS if they had not posted their charges on their website, but no penalties at that time had been imposed. Next slide, please. So on November 15th of 2019, CMS did finalize their proposed policies for the Pricing Transparency Initiative. And that final rule further advanced the agency's commitment to increasing the price transparency, and requirements would apply to each hospital operating in the United States. So this is under the Trump administration, and this has gone further and further over the last several years. And of course now I'm able to go out and search many hospital websites and find those charge masters and those standard prices. Next slide, please. So the effective date for this final rule that came out in November is going to be January 1st of 2021. So they're giving us this year in 2020 to try to meet all, excuse me, all of the compliance with these regulations, and which was great. I was glad to see that. And so you don't have to be too worried unless you don't get your pricing ready and all of the regulations in compliance prior to January 1, 2021. Next slide, please. So there is a fact sheet and then also the final rule, if you would like to read it in its entirety at this web link. So I wanted to provide that to you. And later on in the slides, I think closer to the end, I've also provided the website link to the fact sheet, which is really more, to me, explanatory over the most important issues in this final rule. Next slide. So in this final rule, they did decide to define what hospital is to mean, and they did state that it means that it's any institution in the United States. So they have stated that a state includes each of the several states. The definition includes all the Medicare enrolled institutions that are licensed as hospitals. And the federally owned or operated hospitals, for example, hospitals operated by Indian Health Programs, the U.S. Department of Veterans Affairs, and the U.S. Department of Defense, and are deemed to be in compliance with the requirements for making public standard charges. So, you know, any facility or hospital, including any of the wholly owned and wholly operated sources such as provider-based clinics, rural health clinics, et cetera. And I'll talk a little more about that. Next slide, please. CMS also finalized their definition of standard charges to include the following: the gross charges, the charge for an individual item or service that is reflected on a hospital's chargemaster absent of any discounts, the discounted cash price, which is the charge that applies to an individual who pays cash or cash equivalent for a hospital item or service, payer-specific negotiated charges, the charge that a hospital has negotiated with a third-party payer for an item or service, the identified minimum negotiated charges, which are the lowest charge that a hospital has negotiated with all third-party payers for an item or service, and then de-identified maximum negotiated charges, the highest charge that a hospital has negotiated with all third-party payers for an item or service. Next slide, please. So items and services, they did decide to define the items and services to mean that all items and services, including individual items and service packages that could be provided by a hospital to a patient in connection with an inpatient admission or an outpatient department visit for which the hospital has established a standard charge. So in other words, there's these 5 categories and examples. It's not limited to this, but this pretty much covers every charge that you could possibly have within your CDM. So of course, supplies and procedures covers pretty much all of our devices and implants and supplies, central supply, and then all of our procedures, which could include tests, diagnostic, therapeutic, medical, surgical, all of those items. Room and board charges, use of the facility, and other items, generally described as facility fees, and services of employed physicians and non-physician practitioners, generally reflected as professional charges, and then any other items or services for which a hospital has established a standard charge, which could again mean some of our provider-based departments, whether they're on campus or off campus, could be our rural health clinic, any of those areas. Okay. So some of the services of the employed physician, so this would be physicians who are employed by the hospital or who have assigned benefits to the hospital to do their charging and billing, and those would have to be posted as well. Next slide, please. So 2 required ways for making public our standard charges are with a comprehensive machine-readable file. And of course, like I said, those machine-readable files usually, when I am searching and surfing those hospital internet, then I am finding Excel or CSV type machine readable files. Also, consumer-friendly shoppable services, a consumer-friendly list of some types of standard charges for a limited set of shoppable services. This includes the 70 CMS specified and the 230 hospital selected, which are provided by the hospital. So a shoppable service is a service that can be scheduled by a healthcare consumer in advance. We do believe, they say, we believe these requirements will allow healthcare consumers to directly make apples to apples comparisons of common shoppable hospital services across healthcare settings. Next slide, please. So each hospital location operating under a single hospital license that has a different set of standard charges must separately make public the standard charges that are applicable to that location. So that, again, could be your provider-based departments, rural health clinics, independent labs if you own that. I've seen hospitals who own independent emergency departments off-site. All of those would have to be posted on the internet. So required data elements, a description of each item or service, all standard charges, which are your gross charges, payer-specific negotiated charges, discounted cash prices, minimum and maximum negotiated charges that apply to each item or service when provided in, as applicable, the hospital inpatient and outpatient department settings. Any code used by the hospital for purposes of accounting or billing for the item or service, for example, would be HCPCS, CPT codes, DRG codes, or other common payer identifiers like maybe NDC numbers. Those would all be included. And, you know, back in 2019, when we were first posting our chargemasters, we pretty much just had maybe the charge code, the description, and the price. That's it. Sometimes I would get on and I would just see a description and a price. And so now that is going to change with these new guidelines. And we could, you know, would have to be in compliance by adding, you know, pretty much the several of the different components of our chargemaster, like our HCPCS and CPT codes, maybe our NDC numbers, even revenue codes, those types of things. Next slide, please. So the format, again, I have gone out to a few websites where when I downloaded the chargemaster, it was only available as a PDF. And of course, that Adobe PDF file is not a machine readable format. But like I say, most of the time, and I've looked at a bunch, it has been in either Excel or the CSV. And so that would be what you want to make sure of, you know, when you're searching your own and making sure that you've got that machine readable, downloadable file, that it is in one of those formats. Next slide, please. So location and accessibility, the file must be displayed prominently and clearly identify the hospital location with which the standard charge information is associated. So in other words, if it's charges from a off-campus provider-based department or an independent off-campus emergency center, those types of things, you would need to specify that in the file that you have loaded on the website. The hospital must ensure the data is easily accessible without barriers, including ensuring the data is accessible free of charge, does not require a user to establish an account or password or submit personal identifying information, and is digitally searchable. So I want to talk about that bullet point real quick, because I have gone to many websites that will have me put in my name and my email address. And so based on this regulation, that would not be appropriate. You would not be in compliance if you were having a patient or anyone to put their name and email or address, possibly having to set up an account in order to get to the charge files, those types of things. there can't be a barrier. So many hospitals don't have that. I will say that, but I have gone out to several that have had me put in my name and my email address. And of course, remember, not everyone may have an email address, so that would be a barrier. Updates, data must be updated at least annually and clearly indicate the date of the last update, either within the file or otherwise clearly associated with the file. So that has to be posted. I haven't seen a whole lot of the dates of updates. There have been some, a few. It would tell me the date that it was posted, and then if there had been any updates, then it would tell me the date of the updates. Next slide, please. So this is from the CMS website. This is from their presentation. This is their example of a comprehensive machine-readable file. It's a sample of the display of gross charges only. And so it has a description, the CPT HCPCS code, the NDC number, which is the National Drug Code, the outpatient default gross charge, the inpatient gross charge, and then the ERX charge quantity, which is going to be for your pharmacy, for your drugs. So this is one of their examples, and of course this one only has the gross charges in it. Next slide, please. So hospitals must display the payer-specific negotiated charges, the de-identified minimum and maximum negotiated charges, and the discounted cash prices for at least 300 shoppable services, including the 70 CMS specified shoppable services and the 230 hospital-selected shoppable services. So what happens if you don't do some of those 70 specified shoppable services? Well, CMS says the hospital must indicate that the service is not offered by the hospital and select additional shoppable services such that the total number of shoppable services is at least 300. So if you don't do some of those 70 specified shoppable services, you have to choose additional to make up the total of 70 that you do perform. And then, of course, again, you would choose another 230 for the list to make up your 300. Next slide, please. If a hospital provides less than 300 shoppable services, then you must list as many shoppable services as it provides. So I would think that most facilities do at least 300 shoppable services or more. I wouldn't think that would be that big of a problem. The shoppable services selected for display by the hospital should be commonly provided to the hospital's patient population. Next slide, please. For each shoppable service displayed, the hospital must include a plain language description of each shoppable services. So not our regular limited description like what we have in our chargemasters. Our chargemaster descriptions many times will only allow a certain number of characters, like 23, 42, that type of thing, and makes it very limited on the description, and many times those descriptions are not understandable. So they want these, in these shoppable services, they want that description to be able to be understood by anyone. And group the primary shoppable service with the ancillary services that the hospital customarily provides in conjunction with the primary shoppable service. Next slide, please. Indicate the location at which the shoppable service is provided and whether the standard charge for the shoppable service applies at that location to the provision of that shoppable service in the inpatient setting, the outpatient department setting, or both. So we're going to have to list out, if it's not something that's provided within the hospital outpatient or inpatient setting, if it is provided in your rural health clinic, maybe you're a hospital that owns a critical access hospital. Maybe you have on-campus and off-campus provider-based departments. Those types of things, you are going to have to specify the location and which charges apply to those areas. Next slide, please. So the format, hospitals have discretion to choose a format for making public the consumer-friendly information. However, the location and accessibility of the information must be displayed prominently on a publicly available internet location that clearly identifies the hospital location with which the information is associated. The information must be easily accessible without barriers, including ensuring the data is accessible free of charge, just like I stated earlier, does not require a user to register, establish an account or password, or submit personal information, and is searchable by service description, billing code, and payer. So we've got to have all of that ready to go. And the barrier thing, they mentioned multiple times in the final rule. That was one thing I think they wanted to get across, is that we should not be having patients register, or anyone who is trying to look at the charges, no putting in personal information, those types of things. Next slide, please. And then updates. Like I said, information must be updated at least annually and clearly indicate the date of the last update. That may be more than once a year, because if we change prices or add codes, I mean, just like right now with the new codes and information that we're getting for the COVID-19 virus, we're getting new HCPCS codes for laboratory testing. We're getting some codes told to us for telehealth services, some G codes, those types of things that we may be having to add and create prices for and things like that, you know, mid-year. Those things we may be having to update on our website and not just annually. Next slide, please. And CMS will deem a hospital as having met the requirements for making public their standard charges for those 300 shoppable services in a consumer-friendly manner if the hospital maintains an internet-based price estimator tool that meets the following requirements. So that estimator tool provides estimates for as many of the 70 CMS specified shoppable services that are provided by the hospital, and as many additional hospital selected shoppable services as is necessary for a combined total of at least 300 shoppable services. So there are many price estimator tools out there. If you don't already have one, then you can go out and shop for a price estimator tool, because that is one of the things that CMS is wanting the hospitals to have, and then to give those price estimates for these 300 shoppable services. Next slide, please. So this will allow healthcare consumers to, at the time they use the tool, obtain an estimate of the amount they will be obligated to pay for the shoppable service. Now remember, this is estimate. We've got to remember, with just about everything we post, it needs to say this is an estimate, because many things can happen, as you know, in the hospital charging world and billing world, and this is something that we want to make clear, that this is just an estimate. And it is prominently displayed on the hospital's website and accessible to the public without charge and without having to register or establish a user account or password. Next slide, please. And here's another CMS sample display of shoppable services. They've got the name, like they have colonoscopy under the shoppable service. Then they have a column for primary service and ancillary services. So they've got the diagnostic procedure, anesthesia, physician services, pathology, facility fees. They have CPT and HCPCS code column, and then standard charge for Plan X. They also have office visits. They have one for vaginal delivery. So these is an example of what they would expect to have a display of. Now, the descriptions, I think we can be even more descriptive maybe with some of our services. There's lots of different colonoscopies with CPT codes with different meanings, such as when it's done with a biopsy is done, polyp removals and things like that, that could be different prices. So I think, you can be as explanatory as needed. Next slide, please. So CMS does have the authority to monitor hospital compliance with these regulations by evaluating complaints made by individuals or entities to CMS, reviewing individuals or entities, analysis of noncompliance, and auditing hospitals' websites. So should CMS conclude that a hospital is noncompliant with one or more of the requirements to make public their standard charges, CMS may assess a monetary penalty after providing a warning notice to the hospital or after requesting a corrective action plan from the hospital if its noncompliance constitutes a material violation of one or more requirements. Next slide, please. So now here comes the penalty. So if the hospital does fail to respond to CMS's request to submit a corrective action plan or comply with the requirements of a corrective action plan, then CMS may impose a civil monetary penalty on the hospital not in excess of $300 per day and publicize the penalty on a CMS website. So it's not supposed to be in excess of $300 per day, and I think if I remember right, it was up to $100 and something thousand limit. And the rule establishes an appeals process for hospitals to request a hearing before an ALJ of the civil monetary penalty. So the administrator of CMS, at his or her discretion, may review in whole or in part the ALJ's decision. Next slide, please. This is the CMS final list of the 70 CMS specified shoppable services. I've put these on several slides. These are the evaluation and management services, which has some psychotherapy, some new patient office visits, the initial new patient preventative medicine evaluation. So these are the codes on evaluation and management services. Next slide, please. And then these are the laboratory and pathology services, which contain a lot of our most frequently performed and high volume services, such as the basic metabolic panel, the comprehensive, the obstetric blood test panel, lipid panel, prostate-specific antigen testing, our CBC, which is our 85025. These are all very frequently high volume laboratory and pathology testing. Next slide, please. Then we have our radiology services. Again, a lot of our frequently performed high volume, CT of the head, mammograms, ultrasound of the abdomen, MRI scans. Next slide, please. And then our medicine and surgery services. This is pretty small. Hopefully you can see this. This was straight off of the CMS website. So this has, it's going to have, CPT codes, DRG, HCPCS codes, but, a lot of these are our surgical services, and has some spinal fusions, major joint replacements, hernia repairs, cataracts. There's a EKG interpretation and report, insertion of catheter. These are, most of these are very frequently performed, like our colonoscopies. So, this is a list that you would want to go through and each one of these and ensure that you are providing these services. And again, these are the ones where if you aren't providing some of these 70 shoppable services, then you have to choose others. Next slide, please. So this is where you get the pricing transparency fact sheet that I was talking about. You can put in this web link and go straight to the fact sheet, which is where a lot of this information I'm providing you today is at. Next slide, please. The court has set a April 22nd hearing date. The American Hospital Association has filed a lawsuit about the negotiated charges. So they're challenging the rule requiring the hospitals to disclose those negotiated charges. I don't know now, of course, if this April 22nd hearing date will happen at that time or not, due to a lot of the cancellations due to the coronavirus. But anyway, we'll just keep our ears open and see what happens with this. This is one area that I think, once we know for sure whether or not we are going to have to disclose the negotiated charges, then we'll have to work on that. It may be one that is either canceled or pushed out to a later date than the January 1, 2021. So we will just keep watching for more updates on this. Next slide, please. So this was stated by CMS several years ago. This was back in 2005, talking about the chargemaster is a linchpin within the overall revenue cycle, keeping the chargemaster up to date both for reimbursement as well as maintaining proper compliance as necessary. The chargemaster is a direct and indirect target of compliance for both government programs and private third-party payers. When you think about it, the chargemaster is one of the single most important systems in your facility when it comes to charging and receiving revenue and reimbursement to keep your doors open. Next slide, please. So this is part of the action plan, and I took some of this information from that AHA pricing transparency toolkit that I told you about and added some information to it. So if the patient needs price information from your hospital, where do they go for it? Do they call you? Do they go to your website? Do they talk to business office or other department staff? We have to be prepared. We should be searching our own websites as well as other facilities' websites for pricing and see if it's easy to find and if it's understandable. Do staff members know what to say or how to look up pricing themselves to help the patient? This is something we need to be doing this year while we're getting ready for that implementation date, is to make sure that our staff members know how to find our charges that are posted on our website, and that they know what to say. Next slide, please. So of course we have to train our staff. Communicating price transparency takes both knowledge and sensitivity, and while it's important to have specific staff members designated and trained to fulfill the role, it is just as important to ensure all staff who interact with patients, and that includes nursing staff, social workers, receptionists, schedulers, that they have a general understanding of your pricing policies and know where to direct patients with questions. Be sure also that your switchboard operators especially understand where to forward consumers that are asking for pricing information. So there should be a process for how phone calls are handled, and staff should be scripted to ensure information is consistently provided. Your staff should emphasize that prices provided are estimates, one of the most important things. Alert patients that changes may occur depending on a patient's health or if complications occur. Note what is and what is not included in the estimate, such as maybe physician fees, professional anesthesia charges. Tell patients what other bills that they might receive, such as a professional pathology bill. Those types of things are important too. So that scripting is very important for your staff to have. Next slide, please. Make price information understandable and meaningful. Price information needs to be tailored to individual consumers. Tell consumers how much they will pay out of pocket for care, regardless if they're insured or uninsured. Hospitals should link to insurance company information on discounts, when that's available, and share consumer-specific information on coinsurance and deductibles. Many vendor tools exist that can help hospitals set up systems to pull this information together. Next slide, please. So know how your hospital pricing information compares. Consumer expectations for meaningful price information is growing, and many providers, hospitals, and others are stepping up to the plate to provide this information. And hospitals need to be aware of whether and how others are making price information accessible, and then assess how their information compares. So not just to other hospitals, but to the other vastly growing facility types, such as urgent care centers, ambulatory surgery centers, imaging centers, and freestanding emergency centers. Next slide, please. So use your chargemaster team, also known as like a revenue integrity team. You may call them, the revenue integrity team or a chargemaster team. You may have other names for it, to monitor the pricing information on the website and to train staff members to communicate pricing information to patients. Departments, radiology departments, laboratory, those staff members that interact with patients, they're going to need to know what to say when they get asked about pricing. And search your own hospital website to see how easy it is. Have your own secret shoppers. They're going to go out and try to see how easy it is to find that chargemaster pricing file and that other information that we're going to be posting on our website. Review it to see if it would make sense to the patient or other consumers. Just posting a charge file out there of our standard charges, like our full chargemaster, is not going to make sense to, a lot of folks unless they have, had interaction. Me as a patient, if I'm going out and looking, yes, of course, I'm going to understand, the chargemaster and charges, but my 88-year-old mother is not going to. So, we have to keep that in mind. Next slide, please. So this is going to give you some examples of what I have found on websites. Where is the chargemaster posted on the website? Is it easy to get to? How many clicks did it take to get there? So on this particular website, over on the left, there was a ribbon of services that you could click on. This one was pretty easy. It was just 2 clicks away to get to their chargemaster pricing file. I clicked on pricing, and the next page had the Excel download that I could get to. Next slide, please. So this one was very easy. I understood that, when it said pricing, that's what I needed to click on. If it had said charges, I also would have clicked there. But this is what it looked like. It had the item number, the description, and the price. It was the full chargemaster, just like this example here. And so, again, when we look at the descriptions, some of them are pretty explanatory. Some of them, to the lay person, is not going to understand. Next slide, please. Where is the chargemaster posted? Again, on this website, they had another ribbon for where we could click. There was 3 areas. It took 3 clicks to get there. I chose cost of care. So I clicked on cost of care, and then it brought up a disclaimer and explained about the estimated charges and kind of had a Medicare disclaimer, and then I was able to click on chargemaster, and then it brought me then to the charges that I could download that Excel spreadsheet. Next slide, please. This is what one of theirs looks like. This is average inpatient price comparison. They had the description, the average price, and then they had in here other prices in market. The only thing is it didn't explain to me where those other prices in market were coming from. I didn't know if that was like a core-based statistical area average charge, or if that was from other facilities they were comparing to. I didn't know. And they even had the difference posted. So I think that was the only thing, is I just, wasn't sure where that comparative information was coming from. Next slide, please. This was their outpatient price comparison, just an example of it. They had the description, the average price, other price in market, and then the difference. Next slide, please. And then they also had posted their complete chargemaster with the procedure ID, the procedure description, and then the charge. Next slide, please. And again, next slide. All right. And so is this hospital in compliance? So this was the posted information on this hospital's website. They stated that in compliance with the Centers for Medicare and Medicaid Services, the hospital is making available to the public a copy of its bundled charges. Bundled means the hospital, surgeon, and anesthesia charges are all in one. Before you search through this file to learn what it may cost you to receive an item or service provided by the hospital or clinic, it is important to understand that what the hospital or clinic charges for a service is not the same as what you or your insurance company may pay for a service. No, I didn't see anywhere in here where it said this is just an estimate. I definitely would have put that in there. And then of course, I do agree that, with them saying it is not the same as what you or your insurance company may pay for a service, yes. Then it had click to view bundled charges. So I clicked on that, and you can go to the next slide, please. And this is what came up. So it came up as a PDF file only, and I could download the file, but it is not a machine readable. I could not find anywhere on their website that they had any Excel or other machine readable type of file to download. So to me, this was not in compliance once I got to this file to download. Next slide, please. This was their inpatient example, and then this is their outpatient example, but this was pretty much all that was there were some surgical procedures. There were no emergency department, labs, physical therapy, none of those other ancillary departments. They had just chosen some specific surgical procedures that they had done bundled charges on. So I think partially this is, okay, but we would have to have it in a machine readable format, and then they would need to have all of their standard charges posted, not just these. Next slide, please. So here's another one. This was another posting on a hospital that had their average DRGs posted, the medications, the procedures and supplies, and you could click on each one, and then you could choose whether you wanted to download it in either PDF or a CSV file. So they did have it on there as a machine readable file. Next slide, please. And then this is what it looked like. This was their DRG and average charge. And they had the date between 1/1 and 10/31 on there. It may have changed now. This was one that I had looked at early last year. Next slide, please. And then this was the posting of their chargemaster with their charge code, procedure description, another category, rev code, procedure description, and then the price. And this was in a machine readable format. Next slide, please. Now, really the only way that we're going to know whether our pricing is appropriate, whether our charges are appropriate, is to really do cost analysis. I have this cost analysis tool that we use at some of our facilities, and if you want a copy of this, it's in Excel format, and it has formulas in it where you just plug in your costs and then it will calculate. So this first page, this was an example one for a colonoscopy, and we're entering in, our salary cost, supply cost. Next slide, please. All the way down through, once you get all of your costs entered, then it will calculate the total cost, and then you can add your particular markup. Next slide, please. And this is just showing you. So if you would like this, you can email me, and I can email you the Excel spreadsheet. Next slide, please. So many facilities need to have a charge structure, and so having that pricing policy and knowing what you're going to set your pricing at for each individual department area, because it's not a one-size-fits-all. We really have to be specific when it comes to the departments and the supplies. Next slide, please. I'm just kind of giving you some information here about the Medicare percentage markups and cost, excuse me, cost-based charges. A lot of hospitals will set certain items up based on their cost to charge ratio, and some will take fee schedules and do a markup. Next slide, please. So you have to kind of determine, how are we going to do this for pharmacy? We want to look at ourselves as far as comparison, like with the core-based statistical area average charges. We do those market-driven studies to see where we compare. You can do that through chargemaster reviews, and we use provider metrics when we provide the CBSA information. Next slide, please. And then a plan should be developed similar to your CDM maintenance program policy, if you have one, which will keep the process organized and on schedule. Not every service area is going to be priced the same. Next slide. And then when using a fee schedule payment to set pricing, ensure you're using the right fee schedule for hospital charges. And I've listed out the different fee schedules that you would look at for those different services. Don't use the physician fee schedule for hospital services that are paid under the outpatient prospective payment system on Addendum B. Next slide, please. And then when doing pharmacy and supplies, a lot of hospitals will do sliding scale or use their cost to charge ratio for those high cost drugs and implants. Next slide, please. This is just an example of how to use your cost to charge ratio for setting a high cost device price. This is recommended by CMS back in the 2006 OPPS final rule. This is when they gave us the instructions on how they were reducing items to cost and told us how to use our cost to charge ratio for outpatient CCRs to set our pricing for our high cost devices that have C codes. Next slide, please. And you can do this for blood products also, and use a simulated or your blood specific. Next slide, please. Operating room, again, we have to look at that cost calculation and do that, or use a fee schedule to set the markup. Next slide, please. And then this is the AHA Pricing Transparency Toolkit website that I was telling you about. I would recommend you download this and see their recommendations also. Next slide, please. All right, thank you, and I hope this has helped you. I know we may have some questions, so I'll turn this over to Cassidy Avila.